Hello, friends of the Retina Channel podcast. Welcome to episode 84 of this series. If you're tuning in for the first time, this is a journal club with the aim of discussing select articles in ophthalmology that are aimed in the field of retina. I'm your host, Dr. Keyvan Kushan, and today I have the pleasure of talking to Dr. Rajiv Muni from the University of Toronto about two of his recent publications in the field of retinal detachment surgery. Dr. Muni has been on this show before, but unfortunately not in the past 5 years, so I'm very excited that he agreed to come back to the Retina Channel podcast and discuss these two articles with me today. The first article will talk about Pivot trial, which was a prospective trial that Dr. Muni spearheaded in Toronto and compared with attachment rates for pneumatic retinopexy versus vitrectomy for those patients who were eligible for pneumatic retinopexy. And this recent publication talks about the long-term reattachment rates in these two groups. And the second article is a novel technique for repair of retinal detachment called Spheksy or Suprachoroidal Viscopexy for repair of select retinal detachments, which can potentially make patients' life a lot easier. It's an office procedure with no need for any head positioning and is followed by laser a few days later. It's a fantastic way of looking at a repair of retinal detachment, and I'm very excited to talk to Dr. Muni about this article. Well, Dr. Muni has been here before. Many of you know him already, but for those who don't, I'll give you a brief bio. He's a staff vitreoretinal surgeon at St. Michael's Hospital, Unity Health in Toronto. He also is very active at Hospital for Sick Children and Kensington Eye Institute. He's an associate professor and vice chair of research at Department of Ophthalmology and Vision Sciences in Toronto. He is also the medical director of Ocular Fluid Biobank and Cytokine and Imaging Laboratories at the University of Toronto. He did his residency and vitreoretinal fellowship training at the University of Toronto, followed by a second fellowship for pediatric vitreoretinal surgery at University of Southern California. He also went on to do a master's degree in clinical epidemiology at Harvard School of Medicine, where he established a relationship between serum biomarkers and the time to development of diabetic macular edema in patients with diabetic retinopathy. He has been a recipient of many awards, and especially research awards. American Society of Retina Specialists Presidential Honor Award was his latest achievement. Also, Dr. Clive Mortimer Executive Award for Excellence in Postgraduate Teaching, and also J.S. Crawford Teaching Award has been just a few of his accomplishments. Well, without further ado, this is Dr. Muni. Dr. Muni.
Hey, Keyvan. How's it going?
How are you? I'm good. How are you?
Good. Just running around,
Everything good?
Yeah, things are great. How about you?
I'm great. Thank you very much. Welcome back to Retina Channel podcast.
Thank you very much. Yeah, it's been like 5 years, maybe. I don't know.
It's been 5 exactly. So I knew I had you on the channel, but then I looked up. The last one was 2019. So it's bad for me. You've been very prolific, and I haven't had you for 5 years.
Yeah, no, I'm glad we could do it. So
I'm glad. So we're going to talk about two articles that I asked, and you kindly suggested. The second one, they can relate very well to each other, and they're both surgical, about repair retinal detachment, both offshoots of pneumatic retinopexy. So one is about the Pivot trial, sort of a post hoc analysis of a long-term redetachment rate, and your group looked at that, and you found many of those original patients who you could kind of trace and find what happened to them. And the second article, I was very intrigued by it, about this new technique you have developed and published a case series on, and I never heard of it, to be honest, before, and I'm really curious that we could talk about it. So if that's okay, let's talk about the pivot first, and then we'll just maybe evolve into this new other Spexy method.
Sure.
So for someone who hasn't heard of pivot, most people know about pivot or the results of it at least, but someone who kind of is not familiar with it, could you maybe in 2 minutes tell the listeners and the viewers what pivot was about that you conducted, that you spearheaded the pivot trial a few years ago?
Sure. Yeah. So, as we know, there's so many different ways to fix a retinal detachment. And, we go through our fellowships and, we hear, the experience of our mentors, and we kind of find a strategy that works based on our training, our experience, and also, the kind of system we're in. And I just felt that there was a lot of variability in treatments around the world. And um, you know, unfortunately, not a lot of that was based on science in many ways. We wouldn't have randomized clinical trials that are showing, efficacy or superiority of one treatment over another. Whereas when you look at medical retina, you see like even just for a 3-letter difference or 2 fewer injections, like there's millions of dollars spent on clinical trials. So this is the inspiration, and we essentially carried out a single center randomized control trial that compared pneumatic to pars plana vitrectomy, which was, vitrectomy being the most popular method to fix a detachment, and pneumatic being something that, we do a lot of at our center. So, we wanted to compare the outcomes, objectively, like what is actually better from the perspective of the patient in terms of the reattachment rates, the visual acuity, and also quality of life. And we kind of anticipated that the primary reattachment rates would be lower with pneumatic versus vit. I think that's something that everyone would expect. But we wanted to really focus on, the patient's experience in terms of visual acuity at 1 year as the primary outcome, and then also assess the quality of life for patients. So that was an important secondary outcome. So in summary, what the trial showed was that ETDRS visual acuity was superior for pneumatic retinopexy at every time point, including the 1-year endpoint. And the primary reattachment rate was about 12% lower. It was 81% in the pneumatic group versus 93% in the vitrectomy group. And vision-related quality of life was superior for pneumatic retinopexy in the first 6 months, but then there was no difference between groups at 12 months. So, essentially, the primary outcome, visual acuity, was better with pneumatic. Primary reattachment rate, which was a secondary outcome, was better with vitrectomy. And I think it confirmed the suspicion of many people who do a lot of pneumatics that your visual acuity outcomes are probably superior when it works. But at the same time, there is a lower single or primary success rate. And so you have to kind of balance and weigh that and go to the indications. What are the indications for pneumatic retinopexy? For the the average retinal specialist out there, has to kind of look at the indications and, select the patients that are most likely to do well. Like there's certain groups of patients where you can get 90% success rates, like for single break superior RDs. And then there's other cases like with inferior breaks or larger breaks outside of clinical trial criteria where your success rates are going to be lower. So, you have to gauge based on the patient, what is best for that specific patient. If you have a 50-year-old engineer with a single superior break, probably pneumatic.
Yeah.
If you have a 90-year-old grandmother who lives 3 hours away who just doesn't want to come back for another procedure, do a vit or a vit buckle even, So I think that we learned that pneumatic shouldn't be a treatment that should kind of be marginal, used it only on Friday afternoons when you can't access the OR. I think it requires a little more thinking and trying to select what's best for your patients. And I think the trial data supports that.
Yeah. And you had all comers, right? It wasn't just pseudo fakes or fakey patients or Mac on or just Mac offs. You had everything was stratified and you could
Yeah.
compare
So we
groups
had
within each category?
we had stratified randomization based on foveal status. So we had an equal number of MAC on and MAC off cases in both groups, and we allowed patients to be phakic or pseudophakic. And there was no criteria in terms of the extent of detachment. The only criteria was the breaks. So you had to have breaks in the superior 8 clock hours in detached retina, and all the breaks had to be within 1 clock hour in detached retina. But you were allowed to have any amount of pathology in attached retina. So you could even have like 5 breaks inferiorly in attached retina, but if you had a superior bullous RD with breaks within 1 clock hour, that would still meet the criteria. So that's how it differed from the original pneumatic retinopexy trial that was done in the 80s, where they only allowed pathology in the detached retina within 1 clock hour, but then they didn't really allow any other additional pathology.
Yeah, and in your study, you pre-treated pathology in the attached retina. So if you have lattice or some undetached or attached tears inferiorly, you would treat that before you actually do the pneumatic bubble.
Yeah, exactly. And we're really big on that. I think that any pathology, lattice, retinal breaks, of course, anything suspicious, we treat in attached retina as much as possible. Even when we're doing larger breaks and half of the break might be attached, we will laser that half. We think that, as much laser as you can before to any areas of weakness, our pathology increases your success rates.
Yeah.
And it's something that you can easily do in 5 minutes before the gas injection. Usually, you have a good view, and the retina's attached there. So we do that. Then we put in the gas bubble, and we use a fairly large volume, like I think more than what many people might be used to, which is 0.6 cc's of SF6 is the minimum amount. And I think those two things are really what kind of gives you that higher success rates than what some people might be getting in the community. So, when you start decreasing the size of bubbles below 0.6, I think your success rate exponentially drops off. And I think when you do less laser and you don't pre-treat, and maybe you're less aggressive with the laser after, I think your success rates go down as well. So, I think those are the two things that will, be the difference between like 65% and 85%, for example.
Yeah. And in your institution, your study, you didn't do any cryo for these detachment. They all had laser.
No, we
after
allowed cryo, but it
you
wasn't.
allowed. Okay.
Most of the time we did laser. You could do cryo, and in fact, sometimes we do cryo, and then we'll surround the cryo area with laser as imaging.
Cryo was allowed then. Okay.
Yeah, because cryo takes 5 days to create a scar, and in fact, in the first 5 days, there's no adhesion between the retina. That you create a cryo scar, it creates an RPE. Kind of atrophy of the RPE and the choroid, and all becomes like a scar. But the retina is just kind of flimsy and floating on top of that area, and it actually disintegrates. So it takes like 5 days for that retinal tissue to disintegrate and not be connected to the base of where you've cryoed. So in the first 5 days, if the patient stops positioning, you will see redetachments from the same superior break, for example. Whereas with laser, once you've done the laser, there's a permanent chorioretinal, not a permanent, I should say, but there's some chorioretinal adhesion that's immediate. And so even if the patient stops positioning, it doesn't detach, for the same reason that if you have a horseshoe tear and you laser it, how often does that horseshoe tear detach?
Not often.
Yeah, exactly.
Yeah.
So it's the same thing.
Interesting. Very interesting. Okay, excellent. I know you had some other studies from Pivot, like you look at the metamorphopsia or rate of falls in FAF images, and they're better in the pneumatic group, correct?
The most interesting thing from the Pivot trial was the metamorphopsia results. So, we found that vertical metamorphopsia was worse in the vitrectomy group compared to the pneumatic group. And that just kind of set off a light bulb, because we're like, okay, well, metamorphopsia can only be related to foveal anatomy and foveal structure. So why would, in a randomized data set, why would you have a difference between groups, even with the fact that the reattachment rate was higher in the vitrectomy group. It must have to do with the way the retina is attached in the foveal structure. So then the first thing we did is we sent all the OCTs to an external reading center where we had 2 masked graders to assess the images. And, as you would expect from those metamorphopsia scores, the risk of discontinuities, they graded the times when the ELM or the EZ have like a break in it. Those discontinuities were substantially greater, in fact, in the vitrectomy group compared to pneumatic. And the only cases in the pneumatic group, among the cases that had these discontinuities in the pneumatic group, half of those were cases that failed pneumatic and had a vitrectomy. So we're like, why are these vitrectomies all having EZ and ELM discontinuity? And this is that paper in JAMA that essentially showed that for the first time, that photoreceptor recovery varies based on your surgical technique, which was a foreign concept because before we're like, oh, as long as your retina is attached, that's all you can do as a physician. The rest is up to the patient. I used to say that to people, like, all we can do is put your retina on and the rest is up to the healing of your body. And, I can't do anything more for you. It's just, get your cataract out and that's the best you're going to have. But we now know that's not true. Like everything matters. The type of tamponade you use matters. How long you wait before surgery matters. The type of technique or procedure you use matters. All of those things impact the recovery of the photoreceptors, and we now know that. So now we have to backtrack and forget pneumatic versus vit, but even within vitrectomy, we have to think about how we drain. What tamponade should we use? How quickly do we need to get these patients into the OR? So all of those things came because of that insight from the PIVOT trial. And then we started asking all those questions, and so we found that, the risk of outer retinal folds was greater with vitrectomy. And we learned that, attaching the retina slowly in a gradual manner, like we avoid some of that. We did additional studies and found that retinal displacement was greater because of the size of the gas bubble that you use in vitrectomy. Then we started doing studies looking at different drainage methods in vitrectomy and found that using PFCL or retinotomies was worse than, drainage from the break. And when you summarize all of this stuff together, what we came up with really was that the less you do to get the retina attached, the better your outcomes are. So it doesn't mean that you can, because before, what was the goal for the last 100 years? It was to get a higher success rate. It used to be, Jules Gonin, maybe it was 50%, and then it went to 60, 65, 70, 75, and then you got vitrectomy with buccal and oil in some places. Some places they do vit, buccal, oil. Of course, your reattachment rate is going to be 100% or 98%.
But then are they going to see okay or not?
Yeah, but can they see okay? So then, that was the push, and that was reasonable at that time, because if half your retinas never attach, you're going to get a lot of patients who are going to end up LP or, very bad vision. So obviously we don't want that. But now that we got our success rates in the 80s, let's say for vitrectomy, and, that's kind of the number in most of the randomized trials for all comers, now it's about how can you improve the vision. And, now the imaging was a big change, so retinal surgeons didn't have the benefit of really good FAF imaging and really good on-fast OCT and, and great cross-sectional OCT scans with resolutions of, 4 microns. Like now we can see how the retina attaches. We can see the retinal displacement and the folds and everything.
Very nice, very nice. It's interesting what you said. The less you do, sometimes the better off the patient is. I had a recent conversation with Dr. Saleh Maher from France, and they did a surgical study retrospectively for drainage method using a PFCL versus just natural RPE pump. And people who did not have PFCL, they had less metamorphopsia.
Yeah.
So
that totally doesn't surprise me. Like everything we do to make the retina more attached immediately ends up with worse outcomes. Like I've probably seen this now in 15 different studies in that we've done in different ways. And it's always the thing that the less you do, the better your results are, with the caveat that the less you do, sometimes you don't get the retina attached on the first try. And as a result, like for example, a sclerobuckle, and you don't drain, and it attaches and you get a great result. And sometimes you drain and then maybe you get a subretinal hemorrhage, maybe you get some retinal displacement or other things. And so it's this seesaw. On one hand you have anatomic success rate and you can throw everything in the book to get the retina attached. And then on the other hand, we know that if the RPE attaches the retina, you're going to get the best results. So do less. And so the caveat there is when you do less, if it's not working, you got to move on, so don't sit there, because then you're going to get PVR and other things. So in the pivot trial, if a pneumatic failed, or the surgeon said this is not going to work, you had to get to the OR within 3 days. That was deemed an acceptable period of time. And the other thing that was interesting of the pivot trial was that the mean time to surgery in the pneumatic group was 4 hours, because we do them the same day. In the vitrectomy group, it was 22 hours. So the one thing that I was so aware of was that, the old school thinking that you can do a Mac-off RD within a week. I knew that was probably not correct, because, it doesn't make any sense. The photoreceptors are going to degenerate over time, and
each day could count.
Each day will count. So what I didn't want this trial to become was comparing retinal detachments that were repaired in 7 days versus 4 hours.
Fair enough. Yeah, you gave vitrectomy the benefit of the doubt.
We had to do the vitrectomies, and as a result, the mean time to surgery for vitrectomies was 22 hours, which meant
that's very good.
We were doing a lot of after hours cases, or if it comes on Friday, we did it on Saturday, or we didn't. We only randomized the patient or offered enrollment in the trial if we could meet those benchmarks. We could operate within that narrow window. So if I had a birthday party to go to on Saturday, I'm not going to randomize that patient, because I know I can't do it within the 24 hours. So
if they end up in vitrectomy.
Yeah, exactly.
Gotcha. Very nice. So let's talk about this article you just published in Ophthalmology Retina, talking about long-term detachment or redetachment rate. And so you try to trace those patients back. Would you mind how you did that? And your success rate in finding those patients was pretty high, actually. So how did you go about that?
Yeah, so the one thing is the pivot trial patients we've all kept, and we follow them annually, many of them. I mean, some of them, pass away, some of them have health issues, some of them live far away and can't come. So, but generally speaking, those pivot trial patients, up to a certain point, we are keeping them, because there's an extension study of the pivot trial up to 10 years. But that was hard to enforce, because 7 years in, a patient's 20/20 and they live like an hour away, it's going to be hard to get them to come back. So but essentially we were able to track down.
So you had the contacts.
70 to 80% of the patients, I think we were able to reach. Either they were actively following us, or we called them to make sure that they did not have any other retinal intervention, so any vitrectomy or buccal, pneumatic gas bubble injection, anything like that, we kind of probed them on. Of course, some of them would have had cataract, maybe, or although most of the cataracts were removed. So really, might have been some random thing, like someone had glaucoma or whatever, who knows? But essentially, what we found was that because the pivot trial only reported outcomes up to 1 year. So we were interested in patients after the 1 year mark. So we took patients who were following with us in the clinic for at least 2 years. So in 2 years, 3 years, 4 years. If anyone followed up, didn't follow up, let's say after 1 year, and we never heard from them again after the 1 year, we wanted to know, did those detach? Is that why they didn't come back? So for those, we allowed patients where we saw them at 1 year, but not after that. Then we would call them and say, like, what happened? Did you have another detachment? Did you not? So those patients, we would then have now, it might be 6 years out, but we saw them at a year. So we would include those as well, if we could call them and reach out to them to find out if they had another detachment or not. So, so essentially, the mean follow-up is in the 4 to 5 year range, average. And what we found was that essentially none of the patients redetached. One patient, I think, in the pneumatic group, redetached after a vitrectomy for floater.
Yes.
Yeah.
I found that interesting that the only person who retouched had actually another vitrectomy.
Yeah, exactly. Yeah. But that we know that that happens. And in fact,
It
the
does,
one thing I
yeah.
tell my fellows is like, if you're ever doing a vitrectomy after a pneumatic, be extra careful, like, because those will be the floater patients that could redetach, because when you do a pneumatic, sometimes you treat the offending break, and there could
Yeah.
be another break that you never saw, you never treated, and it was fine, and it stayed attached because it was never a problem from the beginning. But now you go in, you remove the vitreous, you tug on that area, and now there's water
Yeah.
inside the vitreous cavity.
Yes.
That little break that you missed at the original pneumatic could now detach. Or
Yes.
there's retina is a little more friable or prone to having traction, or they have
Yes.
vitreoretinal adhesion that's such that it could detach. So I'm extra careful, I would say, in when I do floaterectomies for pneumatic patients, or in ERM peel or a macular hole surgery, because
Hmm.
I'll probably go around twice and extra slowly, just to make sure I don't miss the smallest possible break. So
Because that's the patient who already developed a break, so it's prone to have another tear, even though it could be small. Yeah.
exactly, and and
Yeah.
and or missed tears, and we find a lot of times I'll find, like, a pneumatic. I mean, they've been followed for a while, but under wide field viewing, you can see a little better, and you find
Yeah.
these little flap tears. So yeah, so that
I
would
like
be,
that. That's a good pointer.
yeah.
Be careful about those fluorectomies, people who had detachment before.
Yeah,
Yeah.
exactly. And even
Okay.
patients maybe who've had tears. So, I think that, so maybe I wasn't careful enough that time, but, essentially, or one of us, whoever did that case, but that patient redetached after the floaterectomy, and then,
Okay.
had a
But it's still
subsequent.
like just one patient out of like 80 or something, right? Yeah.
Yeah, exactly, which is
Yeah.
great to know. And,
Yeah.
I think that that's the general impression out there, is that when you
Mhm.
do a vitrectomy or a buckle, after 3 months, 6 months, that's really the success rate. It's very rare that it's going to redetach. And,
Hmm.
and I think for those people who do a lot of pneumatics, that was also our impression. Like, after 3 months, the risk of failure is
Hmm.
extremely low. But I think for
Yeah.
people who don't do pneumatics, you might wonder, because if you go around the world asking people, relieving traction is an essential part of repairing a retinal detachment, removing the traction. So we put a
Hmm.
buckle behind to to eliminate the tractional forces. We, cut the vitreous to eliminate the traction around the edges of the brake. So you're not doing
Yes.
that in a pneumatic. So,
Yes.
that was my purpose of looking into this, is to
Yeah.
determine uh, whether that mattered. And
Yeah.
clearly it doesn't matter. And it makes sense that it doesn't matter, because we don't cut vitreous traction, or relieve vitreous traction for a horseshoe tear that we laser, and yet the
Yes.
laser holds, and everything's fine. So I think of pneumatic as just going back into time when you just had a break, and
Yeah.
that detachment
That's a good
started with a
way.
break,
Yeah.
right?
Yeah. That's a good
So,
way. Yeah.
so if
Yeah.
you laser the brake, why wouldn't
Yeah.
laser be
Yeah.
enough
That
if you
that's
go
so
back
true.
into time?
That's so true. I like that.
Yeah.
As if you're setting the clock back, before it becomes an RD.
Yeah, and
Yeah.
if we see a horseshoe tear before it becomes an RD, we're not doing a vitrectomy or a buckle. So how does it make
Yeah.
sense to do it for a detachment if you can go back in time and make it into a horseshoe tear? So, and so the data confirmed that, and I think that should be reassuring to people, that you're not going to have this epidemic of patients showing up later, like a
Yes.
year, 18 months later, with a new detachment.
Yeah.
And of
And
course,
these are patients you only looked at the successes, the primary successes
yeah,
of
yeah,
pneumatics, right?
because
Yeah.
we
And I
already
mean,
reported the failures, right? So
yeah.
the failures were already in the first. So we know that 19% of pneumatics that
Yes.
meet those criteria fail, and so those we already know. We wanted to know, among those that succeeded, that we stopped, that we didn't report, that we reported them as a success. How many of those subsequently
Yeah.
detached? Like, if another 10% detached between 1 year and 2 years, and another 10% detached after 2 years and 3 years, now
Yeah.
we're saying the success rates are 60%,
Yeah.
over a 5 year gap, then that changes things, how you look at it. So
Yeah.
we wanted to know whether that was occurring. I mean, I had a hunch that it wasn't happening, but you never know.
Yeah.
Like,
Yeah.
maybe 5 patients who redetached at 18 months never wanted to come back to our hospital, and they went somewhere else, so
Yeah.
yeah.
That sounds very interesting. All right. Well, thank you, Rajiv. This was actually very informative. I like that. I like that, especially the part that you're looking Pneumatic as setting the clock back and getting it to when it was a tear only. So I like that part very much. Um, so let's talk about the extension of this whole journey into Spexy. I'm not sure if you say it the same way.
Yeah.
Spexy. So
Spexy, yeah, or suprachoroidal viscopexy, and it's an in-office procedure. And as I went through this journey with all these studies, we learned 4 or 5 really important principles. Number one was that gas is harmful to the retina, which I think many retinal surgeons don't fully may not fully understand, because unless you look at the forces that you're applying and the amount of stretching of retinal tissue that's occurring with the buoyant force of the gas bubble, it's quite amazing how much force is applied that we just don't fully appreciate. So the gas bubble, and not silicone oil, gas will cause stretching of the retina and displacement of fluid and retinal displacement. So number one, if you can avoid gas altogether, it's probably the best. And so one day I remember I was in my clinic and I saw a patient who had a pneumatic who had retinal displacement. And even though the rate of getting retinal displacement is about 15% on FAF with pneumatic versus about 50% with vitrectomy, I still got it in one case, this case. And I was thinking to myself, it's amazing that, and sometimes we do put larger gas bubbles and things, but I said, even when you don't have a full gas fill, when you put in, 0.8 cc's of SF6, that exerts a lot of force on the retina if it's stretching the retinal tissue, and the mechanism really is very simple. If you take a retinal detachment and let's say it's a bullous superior RD and you inject a small gas bubble in there, the gas is going to float up and the fluid's going to have to move to the side. That's just based on the specific gravity of water and gas. And so what happens is when that fluid is shifted to the periphery, when fluid flows under a thin sheet, if you take a bed sheet and run your hand under it, you'll see that the sheet is moving. There's a drag on the sheet that happens. And so that flow of fluid under an elastic tissue will stretch the tissue. And then if the retina stays in that stretched position, which it will if you have a full gas fill, or if you put PFCL and left it in the eye, or if you've drained and fluid flows under the elastic retina and then gets stretched and stuck down on the buccal, so you need 2 things to cause displacement. You need to move fluid iatrogenically somewhere, and then you need to hold it in that stretched position. And so with a vitrectomy, when you put a 98% gas fill, for example, what's happening is that bubble is occupying space and it pushes the fluid to the periphery. And then that bubble, because it's so large, prevents the fluid from going back. And so now you've dragged fluid to the periphery and you don't let it escape. And then the retina attaches in that stretch position to the RPE. So what our engineers found is that it's the size of the bubble. As the size of the bubble increases, the amount of force of the buoyant force of that bubble also increases. So the bigger the bubble, the more the force you're applying, the more you're going to displace fluid, and the more it's going to stretch the retina. So it's really size related, the initial size of that bubble. And normally we do a full air fluid exchange and everything. So the first principle, try to avoid gas. Okay. And so how can you avoid gas? What procedure can you do where you put no gas in the eye? A scleral buckle, right? That's the, with
no gas.
No gas, exactly.
Yeah.
And the other thing that we also learned about the outer retinal folds is if you attach the retina quickly, you're going to get outer retinal folds, whether you do it in vitrectomy or if you do drainage or you use PFCL. If you force the retina to attach, the corrugations in the retina don't resolve before retinal reattachment, and it attaches in a corrugated manner. And now you get a retina that has these bumps in it with the outer retinal folds. So we also learned, let the retina attach slowly and don't drain. So what other procedure where we don't drain? Well, so we have two procedures, one procedure where we use no gas, which is scleral buckle. Where do we not drain? Well, we don't drain in pneumatics, if you know, in a way, and we don't drain in non-drainage buckles. So, you know, everything's pointing to buckle being the best. You're using no gas and don't drain, do a non-drainage scleral buckle. But why does no one do non-drainage scleral buckles, or very few people do them? Because, you know, it's an invasive procedure. You have to, you know, give a retrobulbar block. You have to, you know, open up the conj, do a, you know, dissect the intramuscular septum, loop the muscles. You know, you're doing these scleral passes. There's risks with drain. With
many fellows don't learn them enough, you know.
Yeah, and we don't do. Maybe we don't do enough. So
yeah.
You know, we came to this, and then the third principle was you want to be able to do something ASAP. You know, a lot of our work is showing that the faster you repair retinal detachments, you avoid, you know, we did this staging system for the outer retinal changes in retinal detachment, and we showed that the longer you go, you know, you get progressive damage to the outer retina, you get bacillary layer detachment, and even macular holes and other things. So the third principle was, we need to do something ASAP. We need to fix it right away. So no gas, no drainage, fix it right away. And so, you know, then it's like, okay, we need an in-office procedure that's like a buckle. And that's kind of how, you know, I thought of doing this concept of that we need to create a temporary scleral buckle that you can do in the office. And the fourth principle was, you know, retinal detachment surgery is hard on patients. Like all of our retinal detachment patients, you know, have to take time off work. They have swelling, major pain
neck
the
issues,
next day. Yeah, big issues. They can't fly for 2 months. They have to be face down. They got to rent the chair, like all of this stuff. And like, how can we make it so that they don't have to do all that? And, you know, usually the better treatments, you know, oftentimes it's like, you know, the patient has to do more to get a better outcome, you know, like, and in this specific case, it's the opposite. Like, you might get a better outcome because it's a more natural reattachment, better vision, and the patient doesn't have to do anything. They don't have to be compliant at all. They can go to work the next day. They can play tennis. They can go to, you know, fly. They can do everything. So the concept essentially is to inject viscoelastic into the suprachoroidal space, and that's something that's been done since the 80s. You know, Poole and Serdansky published in Ophthalmology a procedure where they did a scleral cut down and where they injected this viscoelastic into the suprachoroidal space, and it worked. You know, and but it never came into favor. And then later, several surgeons developed different methods of doing something similar. There's the method involving the catheter, you know, and I believe that a couple different devices where you can take a catheter and go, you know, make a scleral cut down and then advance in the suprachoroidal space to the location of the break. But these techniques, although well described, never kind of took off. And I think most surgeons felt that they were probably a little too invasive, because if you're, you know, you're opening the conj, you're looping the muscles, you're making a scleral incision, now you're passing something between the sclera and the choroid. You might as well, you know, the obvious question is, well, why wouldn't you just sew on a sponge, you know, to that break? Because, you know, you don't have to go into the eye. You can stay outside, safer. You're already there. So I felt like the benefit of a technique like this would only be if you could do it in the office or without opening the eye, essentially transconjunctivally. And so what I wanted to do was inject viscoelastic into the suprachoroidal space and do that in the office. And the other thing that changed also over these years is suprachoroidal delivery of drugs has become more popular as well. And, you know, now it's a more acceptable method of treating patients with a variety of diseases. So, you know, those two things kind of came together. Our knowledge about retinal detachment, understanding that we want to avoid gas and get a high integrity attachment, let the retina attach slowly. We want to do it quickly. Together with the fact that we knew suprachoroidal buckles worked for retinal detachment, along with the fact that suprachoroidal injections were being done in the office now with steroids for uveitis. And so you put those three things together, why don't we just inject viscoelastic under the break, right? And so that's what where it came from. And I would still say we're in a very early phase of this, but what we're presenting in this JAMA publication is a series of 6 patients where we were able to, which had breaks in, and I have very specific criteria for who I do this on. It's people who have breaks that are temporal or nasal in the interpalpebral fissure.
That was my question. How come just those people?
Because in order to get the needle into the suprachoroidal space reliably, you have to have we take a 1 millimeter needle because we put a guard on the needle. So you create a guard so only 1 millimeter of the needle can really go into the eye. So you don't want over penetration. And so by using that guard, you got to be 1 millimeter. But if the needle is not perpendicular, it's going to be less than a millimeter in, right? And so the needle has to be perfectly perpendicular to the break. And so if you go superiorly, think about how hard it would be to get perpendicular to the sclera superiorly under the orbital rim. It's not possible to get perpendicular to it with the current device that we have. So whereas temporally, I can put the needle perfectly perpendicular to the tangent of the sclera, and I can, insert the needle and hold it steady and it be in full control and get the injection. So the chances of getting the viscoelastic in the suprachoroidal space in the spot that you want in a reliable manner is nasal and temporally. Superior and inferiorly, it's very difficult. And so that's why in this series, now we're trying to evolve the concept and develop techniques and devices to make
different needles, different delivery.
Exactly. So, but essentially the purpose of this study was not to tell everyone to go out and start doing this. It's more to say that, look, this works. If you can do it, you can attach some retinas without having to do an operating room procedure, without them having to position, without them having to take 2 weeks off work. They can go on their Christmas vacation essentially. There is when you get the viscoelastic under the break, you can attach a retina, and these patients were amazed that they walked in and essentially walked out, and they could literally go to work the next day. Wow. So when I saw that in the first couple of patients, when I saw that they could return to work, I knew that this is something that's going to be something that patients are going to want if we can perfect the method.
I think there's the future. It's just starting. I think so. We're gonna hear a lot more about this, hopefully, with your future work
so we're putting a lot of effort into developing it into a reliable method. So essentially the results were that in all 6 cases, because we selected areas that we can reach adequately, we were able to
5 of them attached, right? 5 out of 6 attached, so it was very high success rate for a new procedure.
Exactly.
And then they all had laser a day or up to 3-4 days after. So
kind of like a pneumatic. I mean, most of them dry, and you have to understand that these cases, it's the first time we're doing something. So we followed them really carefully, obviously, and we saw them almost every day initially. And we tried to get the laser in because I wasn't sure how long the Helon 5 is going to last, so if the Helon 5 goes away by day 2 and I haven't got my laser done, or day 3 or day 4, and my laser hasn't scarred, I was worried they were going to redetach. So if you look at the pictures in the trial, you'll see like there's a lot of laser, and it's because
I noticed that.
way more laser than I like to do. But it's because you
didn't know how far it's going to
go. I didn't know like what was going to happen. I really had no clue. And so I wanted to, allow this retina to reattach, and I wanted to make sure I got my Pexy in, because I estimated that the Helon 5 would go away in about 10 to 14 days. And I know that it takes 7 to 10 days to create a scar. So I knew that I had to get the laser in the first 3 days, essentially, to be confident that there would be a scar by the time the Helon 5 went away. So
gotcha. And he went away about 2 weeks in general, right?
14 days on average. But the bleb went down faster, so the amount of indent was progressively declining, I would say, after day 9 or 10, so it's possible that you could have had redetachments then, but we didn't. And in fact, we realized that we were doing way too much laser anyway. And if I, now if I'm going to do it, I probably wouldn't apply that much laser treatment.
So,
I would be more confident that it would be fine,
did you have to do much of depression when you're doing the laser? Because I guess you mentioned that in discussion, would the depression displace the viscoelastic or not? How did that go around? When you had the
Yeah,
complete adhesion when you're doing the laser?
yeah. So interestingly, you did not need to do depression because the bleb of the viscoelastic was pushing the brake and making it so easy to see, and the indent was there for you already. So I didn't have to indent a lot, but I was worried about indenting also because I felt that if I pushed really hard in a certain area, that the viscoelastic would displace to the sides of my indentation. Now, it turns out that it didn't. Like, when I was getting close to almost completing a break, but maybe the posterior edge I couldn't, I did do some indentation, and I noticed that the bleb, like the visco, did not easily move. I think it can move a little bit, but it didn't move substantially. So I think that's something that we learned. And
Gotcha. And the one failure you had, you mentioned that you noticed you did not have enough coverage of the viscoelastic over the posterior edge of the
yeah,
tear, I think. So would you
yes.
explain that?
Yeah, so the brake it's like a buckle that wasn't placed properly. Basically the buckle was too anterior and the posterior edge of the brake was still open. And so we waited for a day, 2 days, 3 days, and we saw that the corrugations weren't getting better. We use corrugations a lot to tell us if there's an open break or not. When you have an open break, the retina remains corrugated. When you have a break that's functionally closed, that's not allowing fluid to come in, the water component starts to reabsorb very quickly, and so the corrugations reverse. So we use
Very
that.
nice.
Yeah, so we can use that to tell if the break is open or not. And we essentially could tell by day 2, 3 that there was still corrugation. So I knew the break wasn't closed. And so we immediately did a pneumatic, and we put the patient face down for 6 hours and put them on their side. And, we know
Very
pneumatics
nice.
work really well.
Very
And
nice.
so, which was kind of cool because even though it didn't fail, the patient didn't have to have a major surgery or
Yeah.
anything. And so
Yeah.
it made me realize, like, oh, we're probably going to do like a combination. This procedure is probably going to be, some in office as a primary treatment, but you may also do it, in combination with vitrectomy or in combination with,
Like sort of
you have,
with buckle, do this vexy bit or
yeah,
something.
or a sexy vid, or like a failed pneumosphexy, or like,
Yeah.
all different. I think
Yeah.
people are going to innovate and find so many different ways to apply this. But
Yeah.
it makes sense to do it with, in combination with vitrectomy, because
Yeah.
when do vitrectomies fail? They fail when you have an inferior break and the patient can't position,
Yeah.
and if you put a bleb down now, a suprachoroidal buckle in that area, now you don't need to worry about that area. So
I
now,
think it's a perfect candidate for like
yeah.
combining with routine vitrectomies.
Yeah, and you
Yeah.
can do it in 5 minutes, when it
Yeah.
works
At the end of the
well.
case, inject a bit of a viscoelastic over it, and during surgery, you're more open. You don't have to do a specific needle or something. Yeah.
Exactly. You don't have to
Yeah.
open the eye. You don't have to take an extra 20 minutes. There's no
Yeah.
swelling, like severe swelling the next day. So,
Yeah.
and we've done now cases with vitrectomy, and we've done cases as rescue for pneumatic, and we've done cases in the OR together with drainage. So all of these
Yeah.
papers are kind of coming out, will come out
That's
in the next.
fascinating. That's
Yeah.
congratulations. Great. It's funny
Yeah.
that now pneumatic is your rescue procedure.
Yeah, exactly. Well, it goes to show, like, I think that our interest is not just in like pushing pneumatics, like our interest is
Yeah.
in improving retinal detachment. And even
Yeah.
I had to, as being a huge proponent of pneumatics, obviously all over, I go around and tell people, like, you should do pneumatics instead of a vit buckle for a single superior break. But, even I had to question, you always have to just keep questioning yourself. Like, how can I make it better? What can I, even if
Yeah.
what you're doing is completely going to be outdated one day. And I thought to myself, yeah, maybe, having patients like dangling with their head on their side, like, maybe 100 years from now, that's not going to be considered,
Yeah.
the
Yeah.
up-to-date way to fix a detachment. And, just like
Yeah.
putting sandbags on your eyes isn't, things work, but you have to keep trying to get better. So
Absolutely. I
yeah,
100%
so
agree.
that was
100%
yeah,
agree. The philosophical point is the self-correction is the really hallmark of any sustainable system.
exactly.
Self-correction. If you have self-correction within yourself, your surgical method, or within your institution, that's how things survive and flourish.
And
So
improve,
congratulations on
exactly.
that. That's great.
Yeah, so it's going to be an exciting journey, and we'll see where
Yeah.
it goes.
Very nice. Very
But
nice.
yeah.
Well, thank you, Rajiv. This is amazing. You're a very good teacher. So I learned a lot. So and congratulations on the great work you've been doing and Pivot and now Spexy and other things you've been doing. And I wish you all the best. Thank you for coming to Retina Channel podcast with a very long gap.
Yeah, well, thanks for having me, and congrats on this medium. I know a lot of people listen to it, and it's amazing that you've kept it up for like, I think, what is it, like 6 years now or something? Or
2017. So it's now I
wow,
guess
7 years.
yeah,
Yeah.
7 years. Yeah,
It's
yeah.
great to have
It's fun. Honestly, I learned a lot from it. I get to
right.
talk to people
You don't
like
have to
you,
ever
and
read.
I
You don't have to like read a full journal because you can get the full.
or I actually have to look up
Well, I
things.
guess so. Yeah, you got
Yeah.
to know
So
what you're talking about,
yeah,
right?
but then I get it from the horse's mouth. So
That's right.
yeah, it's really amazing. So, but thank you very much, and this was very good, and thank you for giving me time from your families,
Oh, no problem.
and
Thanks
I
a lot,
wish you all the
Kevin. Always a
best.
pleasure to talk and yeah, and discuss. And even when I discuss on in forums like this, like you just start thinking about like flaws or things you can, it makes you think as well as you're talking. You're like, oh, but maybe that didn't fully make sense or whatever. So
Yeah,
yeah.
I learned a lot. Thank you, Richard.
All right, Kevin.
Have a good night.
You too. Take care. All the
You
best.
too. Well, this wraps up episode 84 of the Retina Channel podcast. Thank you for listening to this episode with our guest, Dr. Rajiv Muni, who gave us a nice overview of these two interesting articles on the repair of retinal detachment. The full references will be in the show notes. Please send me your comments and suggestions to theretinachannel@gmail.com. And I would appreciate any feedback you may have for the show, for areas of improvement, or even articles to review with their authors. And as always, spread the word about Retina Channel Podcast to your colleagues, residents, and fellows. And I look forward to our next episode. This was Dr. Kevon Kushan, and thanks for tuning in.